Okay, good morning. So we're going to go over IDG, everything you wanted to know, but were afraid to ask. I am going to share my screen. And the first thing we're going to go over is this PowerPoint, and I will email this to everyone. And this is directly from Medicare, okay? And it's an MLN fact sheet. Basically, it goes through, what are the requirements for IDG to create an effective hospice plan of care? Because that's what IDG is all about, okay? So, here, the primary goal of hospice is to meet the holistic needs. And that means everything, the whole person, right, of an individual and their caregiver and family when curative care is no longer an option. To support this goal, the hospice provider develops an individualized plan of care. That's something that we all have to work on. The one thing that surveyors and Medicare all hate is cookie cutter plan of care. Like, what every plan of care looks just like the one for the other patient. They don't like that. And it's not giving the patient and their family specifically what they need. So to support this goal, the provider develops an individualized plan of care, and the IDG sets it up. And the RN, when they say RN coordinator, they mean RN case manager. That's who oversees it, okay? What are the requirements as per Medicare? Well, all hospice care and services follow an individualized written plan of care, meets the patient's and family's needs. So the IDG, and that's supposed to include the attending and the medical director, right? Patient and their primary caregiver. So the patient and the caregiver have to be active participants in that plan of care. And the plan of care should be based on any problems or needs that are identified in that initial comprehensive assessment and any updated comprehensive assessments. And what's it got to include? All the services necessary for palliation and management of terminal illness and related conditions. So in other words, whatever that patient and the family need to manage the symptoms and also anything else that goes along with it. That is what the plan of care needs to include. And what do we have to do? The hospice must identify and document the patient needs not related to the terminal illness in the comprehensive assessment, and then tell us who's addressing them. So really, in that comprehensive nursing assessment, everything is covered. It should be. There should not be any blanks, because even if spiritual or social services, let's say for some reason they can't get there within the required first 5 days, and that's not 5 business days, that's just 5 days. So if we do an admission, say today's Wednesday, Thursday is 2, Friday is 3, Saturday, Sunday would be day 5. Anything after Sunday, we'd be out of compliance. So if that's the case and they can't get out there, or if the patient just flat out adamantly, I don't want spiritual, I'm an atheist, okay, we still have to complete the assessment. And that's the way I would explain it to patients. Medicare requires that we assess all your needs. So, I just have a couple questions. Let's just go through this. I know that, you're not into it, I get it, but let's just get through it so I can make sure that we're not missing anything for you, all right? And then we want to make sure that the patient and the caregiver or caregivers get whatever education they need regarding what we're doing, our care and services, right? And that's something that, we need to work on doing a better job of documenting. What did we talk about, right? And having hard conversations with patients and families. So Medicare requires plan of care includes interventions to manage pain and symptoms. So if it's something neuro, manage the neuro symptoms, right? Pulmonary, manage the pulmonary symptoms. We need a detailed statement of the scope and frequency of services necessary. So, when we see patient after patient once a week, nursing, once a week, nursing, is that really sufficient? And it might be, but we need to do a better job of documenting, that's all they need. Maybe they're in a facility and the facility can meet their needs the rest of the time, but are they a home patient? So these are things that, Medicare requires. You need to explain, why did you pick that frequency for that patient? And then outcomes from those nursing statements, right? Remember back in school, we all did the plan of care. So much fun, right? And they're really not that difficult. So the plan of care is you identify a problem or a potential problem, and then you tell me, what can you do about it? What are the nursing interventions and what goals are you hoping to achieve? And the goals have to be measurable. So those goals or outcomes within, like if it's pain, should be within one visit, managed, and then just monitored, right? Because we shouldn't ever leave a patient's house with them in pain, ever, 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 ever. Okay, phone, that's enough. Drugs and treatments necessary, medical supplies like DME, anything else the patient needs, and then IDG documentation of the patient or the patient's caregiver's level of understanding, involvement, and agreement with that plan of care. And we need to do it as a team. And that's a little fragmented right now. So we need to kind of work on that. So nursing, when they say medicine, they mean the physicians, social services, and spiritual care, right? We all need to be working together to meet those needs of the patient. We also could maybe have physical therapy, music therapy, art therapy. In all places that I have worked previously, and Medicare loves this, there really should be one hospice aide representing, at least one at IDG, and there should be the volunteer coordinator or one of the volunteers. And then the patient's caregiver, even though they're not going to be present at the IDG, they're part of the team, if that makes sense, because they have to really approve that plan of care, right? And so what do? What's the IDG team do? Well, we support and manage the physical, medical, psychosocial, emotional, and spiritual needs of the hospice patients and families, set up the plan of care at the time they choose hospice. The plan of care should be getting updated at least every 15 days, right? And then bereavement and supportive services we're supposed to be providing for 1 year after the patient passes, okay? And that's in the standard. So when they show this 42 CFR 418.56A, that is a condition of participation. That's a regulation that comes from Medicare that we have to follow. That's one of many, just, you know. So it's an interesting read to read through all of it. So deficiencies. So when they do surveys, what do they find? So they analyzed 2019 hospice survey deficiency data at the condition of participation for IDG care planning and coordination of services, right? What did they find? Plan of cares weren't individualized. Hospice staff missed direct care visits. And don't get me wrong, sometimes a visit can be missed, but there's got to be a reason, and it can't be staffing. The reason has to be something that patient refused, or, you know, the family caregiver didn't want us there that day or whatever. And then the next deficiency, documentation of visits didn't meet the requirements. In other words, every visit note should stand alone. So when you go out and you see a patient, if the patient has a wound, you go, well, I'm just doing a follow-up. I'm not, you have to at least talk about the wound, right? You have to document something about that wound. That's an example, or about, you know, whatever their primary diagnosis may be. What are they on for, right? Plan of cares were incomplete. In other words, they didn't include all the services that the patient or the family needed. In other words, if we have documented a problem, spiritual or social services has documented a problem, was there an intervention in that plan of care? And, you know, that's a deficiency that they were finding. And then the last deficiency that they found that was very common was the IDG meetings were inconsistent, with plan of cares not being updated, because that's what's supposed to be happening at IDG. And we'll talk a little bit more in depth about that in a minute. I'm actually almost done this, and then we're going to do some Q&A, okay? The RN coordinator, RN case manager, okay, designates an RN. The RN is the coordinator, member of the IDG, responsible for coordinating the implementation of the plan of care, right? So the case manager or coordinator, the RN, is in charge of making sure that everyone is collaboratively, all the members of the team are collaboratively working together to get the patient and their family what they need. Everything, social services, spiritual, everything, okay? We recognize this role as vital to make sure quality care is properly coordinated and delivered in a timely and meaningful manner. And here, this is a compliment to us. The unique skills of registered nurses who are educated to assess and manage the overall aspects of a patient's physical and psychosocial care can be used to oversee the coordination and implementation of care identified in the IDG. And that's the preamble to their final ruling about IDG. And the final rule is the final rule. So that's a big deal. So what is the RN supposed to do? They're supposed to make sure the plan of care is updated on a regular basis, at least every 2 weeks, individualized and relevant to whatever that patient and family needs by continuously assessing the needs of the patient and the family, documenting and revising whatever the care goals or objectives are in a timely manner, communicating with IDG any changes in the delivery of service from what we've already established as the plan of care, easing the exchange of information among the IDG staff, the patient and the caregiver, working with the other members of the team to include additional services like maybe music therapy, massage therapy, and developing and revising patient care goals and objectives together. So we, social services and spiritual, should all be working together to get the goals in place and monitoring for successful implementation of that plan of care. And there are all the resources. So I will send this to everyone. I'm going to stop sharing and I'm going to pause the recording, and then we can have a little question and answer time. So, okay, we are back. I'm going to share my screen and we're going to go to another PowerPoint. And this is one that I kind of put together, and it's, let me get to the beginning of it. That would be nice. And so it's the role of the hospice team, IDT or IDG, right? And what the responsibilities are. So what is it? What are the responsibilities? That everyone participate in getting that plan of care together, that we provide and supervise whatever services and care that patient needs, that we review and update the plan of care, and any policies and procedures that govern the care and services we provide should be, if it's applicable. Let's say there's a new policy, then at the end of IDG, we would say, hey, there's a new policy. We want to make sure everyone's aware of it. Here's what it is, right? That's the time for that. Excuse me. What needs to be done during IDG? The plan of care needs to be reviewed, revised, and documented. What does that mean? I'm going to show you all in HospiceSoft what exactly that means. It doesn't mean that during the meeting we're doing it. So that's where those IDG notes in HospiceSoft come in. So that should be done before the meeting. So this way, when the turn comes to you and it's just a routine patient, you can say, you know, Mary Jones, 87-year-old female, on with the primary diagnosis of COPD. Past 2 weeks, she's gotten worse, as evidenced by she's needing oxygen 24 hours a day, where she was only needing it 10 hours a day, right? That's it. You don't really need a song and dance. You just need to say what's changed. And if nothing has changed, sometimes nothing changes, patient plateaus. Is it because of the care that we're providing? Well, then that's okay, but that needs to be documented. We're giving them such wonderful care that right now they're kind of like plateaued, and that's all right. Okay. And remember, we're going to do Q&A for those that just came in. We'll do questions and answers at the end. So jot your questions down. Okay. All right. And see, I put in red, you must note the progress toward the problems, interventions, outcomes, and goals. So in other words, that's a must. And again, when I go into HospiceSoft, I will show you. Okay. Coordination of services. We talked about this already. And all the services that we provide, nursing care, social services, spiritual, massage, hospice aids, has to be based on the plan of care and the assessment of the patient and family needs relative to what their terminal illness or illnesses are. The agenda for the meeting, I think we all know, the deaths we do first, then we do new admissions. So the RN case manager, some places the social worker presents, oops, there's a little typo, presents the data, the initial data. So in other words, the name, the age, basic demographic information, right? The RN should be giving the physical assessment data, right? And the physician and the remainder of the team would then present once, if they have anything, any input. So, you know, social services did their eval, they can speak. Spiritual did their eval, tell us what you found, right? So new admissions, then we do research, and then we go through the current or routine patients, Then any announcements, like any satisfaction surveys or thank you notes or, feedback from families, and then policy review, like I said earlier, if it's applicable, if there's a new policy that we need to discuss, that would be the time. So a sample presentation, patient's name, age, sex, date of admission, primary and comorbid diagnoses, and then what's been happening in the past 2 weeks. That's for a routine patient. It's very simple, right? Does not have to be a dissertation. So for the RN, what do you need to be talking about? The key history and physical information. In other words, why hospice? Why now? Right? What changed? Medications. I'm finding medications. People are on meds and they're not profiled. Even milk of mag, Miralax, Senna, anything that they're on needs to be profiled, right? What are the biggest issues that this patient is having with regard to symptoms? Is it pain? Is it shortness of breath, right? What is your nursing visit frequency? What is the hospice aid? We don't really do homemakers, but what are the hospice aid plan of care and frequency? And spiritual and social services. That would be the time for them to say, hey, I did my eval and I'm going to see this patient once a month, or this patient doesn't want me back ever again, or I'm going to see them twice a month, or whatever, right? And if the patient is due for a recert or face-to-face, they should be, the RN should be doing a presentation like a recertification, which is almost like an admission. Why are they still eligible, right? The social worker should be giving the basic demographics and the presenting diagnosis, but then they should be addressing psychosocial factors like, are they having financial issues? Is there, who's there, who's taking care of the patient? Is there family, extended family? Is there a private caregiver? Do we need volunteers? And what do we need? What do they need? What education does the family need? And any other, family dynamics. And we all know that families have dynamics, all families. So any concerns or support that's needed should be addressed then, right? So this way the whole team can work on it together. I threw in here some example admission statements, just the basic stuff. What's going on, right? So this is a 78-year-old. I'm not going to read this to you, but you see how I have his age, sex, what's the primary diagnosis, what are the comorbids, how tall is he, what does he weigh, and the weight loss should be represented in a percentage over how much time. Always a MAC, always a MAC, always a MAC. I got to say that over and over again, because time after time, no MAC, because if the patient can't get on a scale at some point, and that's going to happen, then we don't know what the decline is, right? If it's a heart patient, here's the New York heart scale, ejection fraction, what kind of edema, and the JVD all supports his right-sided failure, and the ejection fraction supports his left-sided failure. So I'm very specific in this admission statement. Why hospice? Why now? Well, over the past 3 months, his dyspnea worsened. He can't complete any ADLs without assistance, frequent rest. If the patient's wife or family member or caregiver tells you something pertinent, you can say, wife states it takes 2 hours to bathe him because of his shortness of breath, yada, 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 right? And then at the end, wife is realistic about the terminal diagnosis, however, wishes not to utilize the word hospice. How many times have you heard that? And it's okay not to use the word, but as long as we all understand, one of the nursing ethical principles is veracity, right? Veritas, the truth. We can't lie to people. So they do need to understand what we're doing, why we're there. These people have children that are out of state. They don't help them. And then I talk about the frequencies, right? They need a home health aide 5 days a week, nursing visits 3 times, a week, and then twice a week for the rest of the cert period, and then social worker and spiritual to eval, okay? So for the social worker, again, funeral plans and bereavement, right? That's important. On admission, do we have a funeral home? And they, and I know these are hard conversations, but they need to be had. It's not like we are surprising them. They're signing up for hospice, right? And so, we need to have that information, because sometimes, hey, I admitted one guy last week and I said he's not going to make the night, and he died after I left, 2 hours after I left, you know? So it's important that we have all that information. And then, you know, anything else that's pertinent. Do they need Medicaid? So the social worker could help them with getting the Medicaid application started, et cetera, right? Okay. What is the physician supposed to do? Right? They're supposed to offer input and education to the signs and symptoms of whatever the disease is, the progression of the disease, what's the trajectory based on what we know. What are the best practices for pain and symptom control? And he or she should collaborate with the nursing assessment and the medical records to determine the terminal diagnosis. And I'm going to shock everyone. Medicare actually says they don't have to have the one primary. I mean, there has to be listed a primary diagnosis, but I know a lot of nurses agonize. Oh, what am I going to pick? What? It's not up to you. You do the best that you can do when you're doing the admission. The physician needs to collaborate with the information that we've got. And, you know, cumulatively, what will kill this patient in 6 months or less, right? So don't agonize over that kind of stuff. And I'm recoding most of them anyway. So that's not, you know, you have time better well spent on other things, right? Just give us all the diagnoses that you can think of. And, you know, we're gonna go in and fix it, basically. Spiritual, right? What's spiritual supposed to be asking? Do they have religious background, beliefs? Is there a connection to the faith community? Is there something cultural that affects the plan of care? You know, some cultural traditions are, you know, can influence the way we deliver care, you know? Are there any issues related to love and relatedness? In other words, you know, family issues, spiritual concerns. What is the meaning of life? I'll tell you, it's good stuff, bad stuff, and then we die. Because that is, I mean, we're all just here to have an impact on other people around us. You know, he who dies with the most toys still dies. The idea, I think, my own personal opinion, not related to the opinion and does not reflect any opinion from NJ Health, Hospice, and Palliative Care. I believe that what we leave is just how we've touched people while we were here. That's all we got, right? So these are spiritual questions. We can engage in these conversations, but, you know, we should try adamantly to try to get the patient to let spiritual come in and, you know, talk to them a little bit and see what their needs are. Okay. Okay. And then patients that are currently on census. So either the DON, somebody, director of clinical services, we all have different names. You know, we should be doing it in the same order. Believe it or not, Medicare says the social worker goes before the nurse. Now we can flip them and have the nurse, then the social worker, the physician, spiritual and volunteer coordinator, right? But the presentations need to be consistent and need to be brief, you know, succinct, to the point. Because when we have 80, 100 patients, you know, we can't be in, nobody wants to be in IDG all day, right? And so we want to be able to get through it so that we're prepared when we walk into that meeting. Here are my patients, here's what's going on, ba-boom, 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 right? And we can get in and out in an effective, efficient way. So the social worker for the current patients, whatever are the most pressing issues now. Are there any community resources involved that weren't before? Are there any like new family members? Hey, the estranged son just showed up last week. And any changes, change in the plan of care, change in the visit frequency. For the RN, again, the patient, admission date, age, diagnosis, goals, what are we looking at? What are we trying to accomplish? Are we having problems managing pain, managing shortness of breath? Are they refusing to wear their oxygen? You know, any changes in the level of care, changes in the visit frequency, and the hospice aid or homemaker plan of care changes should be discussed if they're applicable. And for research and face-to-faces, again, the LCDs are the guidelines for determining terminal illnesses. And the doctor, the physician, is the one that can, you know, look at this and say that this diagnosis is or is not appropriate, right? That's outside our scope of practice. The physician can recommend pain and symptom management options. If there's something that's, you know, not working and we you know, what else can we do? Also pharmacy. Diagnosis specific education if needed. Physician review the IDT notes, other documentation, look at the research and, you know, the CTIs for the research, et cetera, et cetera. That's the physician. The CTI, So this is an explanation. If anybody wants to see what Medicare says about what the CTI must include, there is the link at the bottom of that page, right? See what it says here? Although the principal diagnosis is not a required component of the CTI, the narrative needs to explain why the patient has a 6-month prognosis, and it should take into account the principal diagnosis and other conditions that make the patient terminal. So in other words, would you be shocked if this person passed away in 6 months or less? If the answer is no, and it's cumulative, that's okay. We can figure it out. Medicare says that's okay. Okay. And then spiritual counseling, again, for the routine patients, what issues are going on, if any, right? Are there any changes in the visit frequency, any changes to the plan of care? The volunteer coordinator, again, any changes? And then, you know, when we talk about the patient deaths, typically the bereavement counselor leads that. Right now, we're not doing it that way. That's the goal. Now that we've got 2 teams, we're going to try to get this working like a finely oiled machine. But the list of the names of who passed, and then the criteria, like, are they high risk, low risk, or moderate risk, right? Any extenuating or unusual circumstance. If there's anything funky that you want to share about that death, then, you know, it's okay to do that. But it shouldn't be a grief session. It needs to be like, you know, brief. And if there are issues of grief, we can refer people to, you know, staff members to counseling if need be. Here we go, team grief issues. So the COPs tell us that grief issues for the team have to be addressed. I found when I worked in the ER, for me, you know, when babies, young children passed, that was hard to watch. But, you know, I mean, I guess the ER changes your outlook on things. I've been doing this a long time, but it can be difficult when something out of the ordinary happens, or something that's, you know, kind of touches you in a different way. But we can't dwell on these things in a non-productive way. We have to focus on the team's emotional and spiritual pain issues, and then talk about, well, what did we do to make it better for this family and this person, right? So focus on the positives. And then wrapping up the meeting, right? What are we doing? Discussions that are going to be over 10 minutes on one patient need to be moved to a separate meeting. Okay. So if there's a difficult client, or if team members are disagreeing about what he can stand, no, he can't. Yes, he can. No, he can't. Not the time for that, right? So anybody that's involved in that, we can schedule a separate meeting, whether it's via Zoom or whatever, to iron it out. But at the time, it's not during the case conference, right? Okay. And then time management. You know, 45 to 50 patients in 2 hours, reasonable, right? And it has to move along quickly. And if there's an issue where, oh, you know, we don't know what we're doing with this one, we have to kind of table it and then maybe do that at the end or something, if it's something that's really time consuming. But we should be prepared when we go in so that we don't have these issues, you know, so we can move along kind of, you know, as efficiently as we can. And then at the end, we can talk about, you know, any thank you notes and that kind of stuff, surveys from families, any announcements that we need to make. Now, I'm not going to go through the rest of this because it defines the role. And I pulled this directly from CMS, the role of the medical director, the hospice nurse, the hospice aide, social services, etc. So I'm going to email everyone this PowerPoint as well as the previous one. So this way you can all see it and refer to it as well as this. Okay, I'm going to pause the recording now for any Q&A that we have about that one. All right, I'm going to share my screen and we are going to go to HospiceSoft, but the sandbox, which is kind of the fake HospiceSoft. Okay. I'm just going to throw a diagnosis in here. So I'm going to, let's do cardiac I-25. We'll do CAD. Ischemic cardiomyopathy, and we'll make that the primary. And it should be January of 2022. I think that's when this guy was admitted, fake admitted. There we go. All right, so this is John Doe. How corny can we be? And here's John Doe's chart, okay? So when we scroll down through the face sheet, We go down here to the tabs. There's a yellow tab that says IDG forms. And in that yellow tab, there are 3 sub-tabs. There's the Combined Disciplinary Comprehensive Assessment, the Combined Disciplinary Plan of Care, and then the Interdisciplinary Note, okay? So I'm gonna start with the Interdisciplinary Note. That's the easiest part. Well, they're all easy, really. The note is what you would write, and you means social services, spiritual, and nursing, right? Just a quick blip about what went on in the last 2 weeks. So I'm going to go over here and I'm going to create a note, and I'm going to make it for the date of when this guy was, you know, admitted, and was like January 21st. And I'm going to create the note, right? And then it opens up 2 sections, right? One section is the patient basic information, their name, their date of birth, and their medical record number. And then the second part of the section is the note. And the note should be just like I said. If it's an admission, you can take your admission summary. Same if it's a research, take your research summary and paste it in there. If it's just a routine, so this patient has declined as evidenced by, I'm going to say increased dyspnea with SpO2 desaturating with speech from 90% to 88%. So there's his decline, right? So that's, he's got increasing shortness of breath. We should never click log visit count on finalization, because that means that this was an actual visit that was done. So it's a team note. All we have to do is click other. And then who wrote the note? Well, I'm nursing. So that's me, right? So I'm going to click that, and then I'm going to click save so that it saves it. And then I'm going to click back. When I go back and look at it, now it's got a little green check mark. That means it's ready to be finalized. So I just go over here, I click finalize, and there you go. Now it's locked. So that's the interdisciplinary note. Just, it should be 1 or 2 lines from nursing, spiritual, and social. Now, these other 2 tabs, we have the Combined Disciplinary Comprehensive Assessment. And here, look at this. Oh my goodness. What's happening is the system will create one for you from the time the patient's admitted. This poor guy has how many pages? 5 pages, because he was allegedly, you know, make-believe admitted back in January. Every 2 weeks, it's going to create one for you. And it will pull the information from your notes. This is the important part that you need to know. So in other words, let me go into the most recent one, which this one, and I'm going to go in and see if it'll let me edit it. When I click edit, look at this thing. There's no nurse note visit, right? There's no social worker visit note. There's no spiritual visit note. If there were, if this were a real patient, there should be notes from each of those disciplines. You could click reload patient information, and it will populate the information from each discipline from the most recent visit note. Okay, so when it does that, the only thing that will show up in red is this one down at the bottom, the IDG approval. And that's asking you, did we collaborate with the attending physician? The answer better be yes. Did our hospice physician review it and approve it? Should be yes. And then all of these, I mean, I don't do the pharmacist because we don't really go with the pharmacist, but we can click pharmacist. They should all be a yes, right? Unless it's not applicable. Now here, there's a dietary counselor. We don't have that included in our real HospiceSoft, but this is the sandbox. But reviewed and approved by the nurse, the social worker, the spiritual counselor, bereavement, the volunteer coordinator. Those 5 critical yeses. And then I'm going to click save. And then when I go back, I can click finalize, and boom. So there's our combined disciplinary comprehensive assessment. It pulls from the comprehensive assessment from each of the three main disciplines: nursing, social, and spiritual. Now, for the combined disciplinary plan of care, which is this middle tab, okay? Now, this will do the same thing, except the problem here is that this patient, this fake patient, see all these, the status is red, and it doesn't say edit on any of them because no one has done anything here since the patient's admission. So I'm going to go all the way to the very first one. Now, see, this one says edit. Now, you normally wouldn't do that, but you should go to your most recent one. If you come across a patient, and you will, that's been on service that you've picked up, and they have all those incompleted ones, send me a text or an email so that I can go in and fix them for you. It takes a while. It'll take me probably, an hour to fix one case. But send that to me so that little by little we get them all fixed, and I'll pull from the previous notes to get them all updated. Okay. So let's just say we didn't have that problem here. And now we're going to look at the combined disciplinary plan of care. When we click edit, it's going to open up this form. And this will also pull from the spiritual, social, and nursing notes. But see how it's saying here, there's no nurse visit note, there's no social worker visit note. So it doesn't have anything to pull. But on a normal patient, there should be a note from each of those disciplines, and it would pull the info. All you would do is click reload patient info, and it should pull the info. Here, it's going to ask for a visit type. So in other words, is this the initial one or is this a routine one? I'll show you in a minute. There we go, right here. Visit type, it's either initial or routine. So let's say this one is a routine, okay? The sections that are in red, there are two sections in red that you must complete. I'm gonna go to the bottom, IDG approval. It is asking you, and you won't have all of these, by the way, because we took these out of our forms, okay? It will ask you, was the medication profile reviewed? Who was it reviewed by? So was it reviewed by Dr. Olarsh or by Dr. Caballas? Because there are two medical directors. And what was the date that it was reviewed on? Okay, so let's just say it was today to make life easy. Okay, and it should be the date of team. You're not going to have all these things, but what you will have down here is, was the plan of care reviewed and approved by the patient and or family caregiver? Hopefully you better check yes. Right? And it's going to ask for something. So in other words, I'm going to say here, patient and spouse approved. Oops, you can spell there, right? Did we collaborate with the attending physician? Better. Did we collaborate with facility staff if the patient is in a facility? If not, we click NA. Was this reviewed and approved by the hospice physician? Better be a yes. Did the nurse approve it? Did the social worker? Did the spiritual? Did bereavement? And did volunteer? They should all be yeses, right? And then, right, any comments that you would want to write here, you don't have to, because this is pulling all of the plan of care items. So in other words, let's go up to the top. The basic patient information. The reason that this one is red is because there's no admission date and no diagnosis for this guy. So it's fine because this is a make-believe patient, but that would be there for you. When we click the IDG info box, it's going to tell us whatever the date is today. Is that the day of team? If you're doing this note before the day of team, then just fix it. So our team is next week. So we're going to say August 31st, right? Is the IDG review date. And the one after that is going to be September 14th. And is this a routine or is this an admission? So this is going to be a scheduled routine review. If it were an admission, we'd click admission. And then all of these sections are going or should be pulling your care plans from your notes. Spiritual should have a care plan. Social should have a care plan. And so should nursing. So, and I will talk more with spiritual and social so they understand, the plan of caring and planning of care rather, and what needs to be done. but this is not pulling anything up because there were no, there's nothing in here for this make-believe patient. But whatever was in the notes, we'll extrapolate here. And then once you're done going through it, just to make sure, are there any changes? So in other words, if this patient did have a pain issue, let's say the patient had a pain issue, their pain wasn't controlled with current medications, right? I'm going to say patient not taking meds as ordered. I'm going to say fear of addiction or something, because we get that sometimes. Fear of addiction. So this is a current issue. Well, what are we going to do about it? Here are the goals. And I don't like their goals. Let's see, verbalize, nonverbal, regular, bowel, acceptable. Now, see, I don't like the goals. So I'm going to make my own goal here, and I'm going to say, patient will verbalize understanding of pain management regimen. And then I can write more in here, explain addiction process, whatever I educated them about. And what's the time frame? So patient will have pain controlled within one visit. And the reason that's important is because you would never leave someone in pain, right? So the goal is in one visit, their pain's going to be controlled. That's current. And then the interventions. What are we doing for this patient? Explaining the addiction process, explaining getting ahead of the pain so that the pain is not ahead of you, and how much more difficult it is to control that pain, yada, yada, yada. I'm the nurse. Yeah. Here. I'm just going to say educate patient regarding blah, 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 pain management, etc. I'm the nurse. I'm doing it, and it's current. Right, and then I can click save up at the top. Let me move this out of the way. And I'm going to go back. And what's going to happen is this is going to come up with an orange next to it. See, status orange. So that means it's in process. Oops, click that. All right, it's in process. So it's not finished yet, so I can't finalize it. But with your patients in real HospiceSoft, you should be able to finalize it. If you cannot, because there are all these previous additions that haven't been taken care of, please text me or email me patient name and IDG issue, and I'll go in and fix it for you. Okay. And the only day I'm not around is Tuesdays. So you can't get a hold of me on Tuesdays. Okay. So those are the 3 sections. And again, the first 2 sections should be pre-populated based on the notes that have already been written. I'm going to stop my share, and I'm going to stop the recording.